So, to complete part two, and this one will be much shorter, we're going to start with correcting errors. So, we have taken an image, we have looked at it, decided that it is unacceptable, and now we have to determine how to correct the issue. So, is it worth repeating, or can I fix it in some way so that it is diagnostically usable? And so the things we have to look at is this a technical issue? So I'm going to look at my exposure indicators, and I'm going to use that as well as my image quality to let me know, did I send enough signal through? Is my signal to noise ratio high enough here? Do I see quantum model that is obscuring bony trabecular pattern? Is my image way too bright or way too dark so that I can't see what I need to see? Exposure indicators are a great way to kind of guide you on what the problem is. However, and you guys are going to get the lovely experience of Dr. Millman, our physicist, who's going to come in and talk with you all about the exposure indicators. She is incredibly knowledgeable on this topic, and I'm very sad that I can't be there. I absolutely adore Dr. Millman. So I hope you guys really enjoy that and learn a lot. Is the next thing we want to look at? Something else I wanted to say on the technical issue. Sorry, I was fangirling about Dr. Millman. Don't tell her I said that. The exposure indicators. So we've talked a ton, and you know a lot about ALARA, as low as reasonably achievable. But exposure indicators relate to as low as diagnostically achievable. So you may run into times where your exposure indicator says that you are super underexposed or super overexposed. But you look at your image and your image looks fine. There's not a ton of quantum model, if any, or it's the contrast and brightness is right where it needs to be. You'll see your exposure indicators get really messed up, especially if exposure field recognition is messed up, or the auto cropping that it likes to do for you is messed up. So just if you ever see that happen where the white border outside of your collimation is showing up, or the machine automatically crops and it crops out all the usable anatomy that you wanted, look at your exposure indicator before you fix it. And I guarantee you it will change when you get your image opened up to what you want to actually send to the radiologist. Next is going to be a procedural issue. So is this something that I did during the procedure, or did the patient move? Is there incorrect positioning? Did I not prep the patient, or are things out of alignment? Do I have an angle on my tube? Is my image detector at an angle? Did my patient move and now their part's at an angle? Do I have OID? So is this something that I, as a tech, messed up on, or something shifted during my actual exposure? Before you go in and start moving things, if you determine that it's likely an issue on your own part, make sure that when you walk back in the room, you look at what's going on. Just a bit of advice too, if you are doing like a knee or an elbow or something where you have to get condyles overlying, or you really are trying to get parts into alignment with each other. For your patient instructions, tell them to hold still until you let them know it's okay to move. So we'll use a knee as an example. If you get a patient in position and you take an x-ray and you didn't instruct them to hold still until you told them otherwise, maybe they hear the beep and then they start moving. And then you look at your x-ray and you notice that there's a rotation issue. If your patient just moved, it is so difficult to get them back into the exact position that you just had them in, to then be able to make the correction that you need to make. So have them hold still, and if you see your x-ray, you recognize that it's a rotation issue, and maybe you see your adductor tubercle, and so you know that you need to externally rotate a little bit, then you're able to easily go into the room and shift your patient just a little from the position that they were in during the exposure. So just kind of keep that in your mind as you're moving forward with some of these things. And then, did the equipment malfunction? So is this an actual equipment issue that you have no control over? If it is an equipment issue and you know that there is, or you don't know that there's a fix, don't try to repeat the exposure. Report the malfunction, replace the equipment, move your patient to a different room, get a different portable to them, whatever it might be. Replace the CR, PSPIP, whatever correction you need to make so that you're not going to continue to expose them and it's just an image that isn't usable. Okay, so exposure errors. Overexposure occurs when the image receptor receives too much signal, so too much radiation is getting through. This can be referred to as too hot, saturated, excessive density, and this is referring to kind of saturation. It is density of X-ray that has reached my detector. This is not referring to patient density. So please make sure that you get those straight in your head. There is patient density that is going to show up as super bright white if they have really dense bone, if they have hardware, and then it is exposure density or like excessive density to your detector that leads to overexposure. So think of it as like your pixel. How much is my pixel picking up? And so if it has a lot of density being added to it, it's getting saturated, it's getting too much information. And so overexposure appears as super dark, blown out. It's just too much signal. So as we talked about before, data clipping can happen. Iliac crest is the most common when I've seen it, but it can happen in other areas as well. And then light or dark lines can represent DEL saturation, or like a TFT line is down because it got too much information and kind of short-circuited that line, that gate. Underexposure occurs when the image receptor receives insufficient signal. So not enough X-ray, and it's too low, photon starvation, insufficient photon density. The image appears very light with quantum model in denser anatomical areas, or SNR is reduced. So if we look over here, here's my normal knee X-ray, then this is underexposed, way too bright, way too light. There's going to be quantum model if I zoom in on that. And then this is going to be overexposed. Remember, underexposure at 80% underexposure, too light, too bright, can't be used. And then overexposure, I can get up to 500% overexposure and still have a usable image. And then these others are just demonstrating exposure latitude and dynamic range. So we mentioned that, or I mentioned that 500% overexposure. That's significantly different than just 80% underexposure. So I have less wiggle room when it comes to underexposure. And I have a lot more space, a lot more freedom in overexposure. And so for a while, this led to techs sending too much technique into the patient and just increasing their techniques so that they always got a usable image. However, this does not follow ALARA. That is exposing your patients to too much x-ray, and it is going to increase the dose to your patient. So, to be a quality technologist, you want to use all of the concepts that we're teaching you and keep your doses as low as possible. Not only is that going to protect your patient, but if for any reason someone needs to hold, you need to hold, especially if you're up on portables or in the OR or CR, like using a C-arm, you're going to protect yourself and everyone else around you as well. So, this tendency to use too much technique is known as dose creep. So we're just kind of creeping our techniques up a little bit so that we always get a diagnostic image. And so we want to prevent dose creep. I used a lovely Frankenstein bit emoji here, but I just imagine this little guy kind of creeping around. So make sure that you are keeping your doses as low as diagnostically and reasonably achievable. So dose creep, it comes because our digital imaging systems, they're capable of producing that optimum brightness, even if we give too much exposure. And so just make sure that you are maintaining as low of a dose as possible. And use your exposure indicators to help you, to help guide you. So there are lots of different vendors, and vendors have their own exposure indicators. And so you guys are you've hopefully been exposed to a lot of different exposure indicators at this point. And what you will notice is that they're not standardized, they're all different. So exposure indicators happen during pre-processing, and they are a result of the histogram analysis. And so it's a numerical value that indicates the level of exposure received by the image receptor. So essentially an exposure indicator, when I set my technique and I set my parameters, and I have my lookup table that's set for, we'll use a femur again, and I take an image, and what happens is during pre-processing, the software takes the signal that it receives and compares it to what it was expecting. And so it is, if it got more than what it was expecting, you're going to get an exposure indicator that is oversaturated or too high. If it receives signal that is less than what it was expecting, you're going to get an exposure indicator that indicates underexposure. And so that's kind of how they work. And they're comparing to the histogram and the histogram to the lookup table to kind of identify, was this underexposed? Did I not receive enough information or the information that I was expecting, or did I receive too much? Exposure indicators are not a representation of patient dose. They are a representation of what hit your detector and what the detector was, and comparing it to what the detector was expecting. So this is an example of deviation index. So you see this on the GE room in AOP. So let's say I took an x-ray at 30 Mass. And that is what for my femur, and I'm using this as an example. If that's not the femur technique Leah taught you, please, and don't come at me. So we'll use this just as an example. So I took a femur and I took it at 30 Mass, and that's what my receptor was expecting, and so it gives me a 0 here. It's like, oh, that was a perfect representation of this femur. That you sent me the information that I was expecting. I got the information that I was expecting. And then hopefully your image looks perfect as well. Well, let's say as I was talking to the patient, I was looking at, like, paying attention to their anatomy. Patient looked a little smaller, so I decreased my technique. And my detector was still expecting 30 mass, but I only sent through 24. And so it got a little less than it was expecting. And so my exposure indicator, my DI number here, gave me a -1. And so it didn't quite get what it was expecting. And honestly, and from what I have been told by multiple sources, though I have not found this in a textbook, is that we kind of want to be around a -1. We want to be just a little bit below 0. And that's following ALARA, as long as my image is not showing excessive mottle. And then conversely, let's say the patient, I wasn't paying attention, and I clicked, accidentally increased my technique instead of decreasing it. And so the system was expecting 30 mass, but I sent through 48. And so now I have overexposed my patient, and my image is probably going to look a little darker, and then I am going to get a higher DI number. Now, all these others are examples of other systems. So you might see a sensitivity index, and that's going to be indirect. So sensitivity, if the sensitivity number was really high, that indicated that I had an underexposed image. Whereas with a deviation index and our exposure index, which is what Siemens uses. So Siemens uses EI or EXI. GE is using DI. So deviation index is direct. So if I'm up in the plus, I have overexposed. If I am down in the negative, I have underexposed. Same with exposure index. If I have a really high exposure indicator or index number, then I have overexposed. If I have a really low exposure index number, I have underexposed. But remember, these are not a representation of patient dose. Here's just another way to view these and kind of see this as far as directly proportional, indirectly proportional. So Fuji uses sensitivity values. So the target would be like 200. You wanted your S number at 200. But, I got an S number of 400. That means that I have underexposed my patient. Whereas lower numbers meant that I had overexposed. And then Siemens, it's going to be direct. So maybe the target number. And there are, I have provided you guys with the actual sheet that you will find in clinic. There is the target number for chest x-rays. It differs from all other parts. So make sure that you look at this sheet in your departments. It's on Schoology as well. But this one is going to be direct. So if I get, let's say for a part it was 400, but I got a 600, I have overexposed. If I get a 200, I have underexposed. I forget exactly what it is, but I think target for chest x-rays is like 125. I don't know. I'm not going to tell you guys the wrong thing. Please just make sure that you look it up. And for all of these, I do not expect you to memorize them. I am not going to test you on the sensitivity values for Fuji or Siemens. I want you to know Siemens and your deviation index, your DI numbers for GE, just because those are the systems that you're working on. And I expect you to, like, if I come into clinic and I ask you a question about your EXI number, I want you to be able to answer it. But I do not expect you to memorize all of this stuff. I just want you to understand that some systems are indirectly proportional and some are directly proportional. Okay, exposure indicators. Remember, not a representation of patient dose. However, they can be used to adjust our technique and stick to ALARA and ALATA. The controlling factors for our exposure indicators are going to be our mass, our KVP, the field of view, and the density of the anatomy. So obviously MA is going to control the quantity of x-rays as well as how long my x-ray exposure actually is. So that determines receptor exposure. Receptor exposure is going to be directly related to my mass. So if I increase the MA, or the quantity of x-rays, I'm going to directly increase my receptor exposure. Also, if I increase the time, I am going to directly increase my receptor exposure. KVP, that's my penetrating power or the quality, that is my potential difference of the x-rays. And so that is affected, my receptor exposure is affected in relation to my 15% rule. So if I increase my KVP by 15%, I didn't really take into account my mass. I have increased my receptor exposure. Field of view is going to be the area of the exposure. So the larger the area, the more x-rays have a chance to scatter, and the more it's going to affect my receptor exposure. So collimation is key here. So collimation, we've already talked about how if I collimate to my anatomy of interest, I'm going to decrease scatter, I'm going to improve my visibility of detail. So just make sure you are collimating, because that is going to decrease the amount of dose to your patient, and it is going to directly affect your receptor exposure. And then your density of anatomy. Extremely light or dense structures can cause exposure indicators to appear skewed. So let's say I took a picture, I took an x-ray of a patient, I was x-raying their hip. And I set a technique for what I would normally shoot a hip at, but this patient is incredibly osteoporotic. And so their bone just doesn't have the density that I was expecting. And so I'm going to have a high exposure indicator, because what I was expecting, what the system was expecting, it got more information or more x-ray saturation to my detector than it was expecting. And so now I have a darker image than I was expecting. The opposite can be said. Let's say I took a picture and I hadn't asked my patient if they had surgery before. And so I didn't realize that they had hardware in their hip. And so now I have an extremely light image, and my exposure indicator is letting me know that I have underexposed. So that's how density of anatomy can affect my exposure indicator. And then just a reminder, noise is any type of signal interference in a digital image. Quantum model is referring to the actual amount of x-rays that reached my detector. If I don't have enough, I'm going to get quantum model. I'm going to see this old TV graininess on my image. So exposure indicators, just kind of looking at it here, a low exposure indicator, if I'm using a Siemens room, is going to indicate underexposed, and I can see all of this quantum model here. I can't see even the head of my humerus. I can't see where the scapula is. This is super bright down here. I have an artifact with the patient's necklace. So underexposure versus an acceptable exposure. And then I have an indicator number that represents a good exposure. Notice that I can see the joint space. I can see the humeral head. The artifact is gone. Yay! All right. And then high exposure indicator. Now, this one's a little tricky. So I see quantum model here. But notice that my image is dark, and also I'm not centered over the part that I'm x-raying. So maybe I set a really high technique, but because my part wasn't centered correctly, the cell that was detecting my actual technique, it got to the technique, or it timed out, but it wasn't actually penetrating anything that I needed to see. It just got tissue. So this can be where exposure indicators can be a little tricky, and you have to rely on evaluation of your actual image. And then obviously a correctly exposed image over here. So for this one, you would have to repeat. You can't see what you need to see here. You would need to make sure that you centered correctly and adjust your technique if necessary. All right. Thanks you guys for sticking through all of this. Please reach out to me if you have any questions. Send me emails. I will be back on Friday, and we'll get back to you as quickly as I can. That'll be my first order of business, is answering any emails that you have. So thank you guys again, and I hope this is super helpful. And have fun with Rebecca.